geriatric assessments. So you're going to look at the normal findings as well as the abnormal findings. We're going to describe the purpose and results and nursing responsibilities related to some of the diagnostic studies for the GI system. And then we're going to review the etiologies, the manifestations, complications, diagnostics, treatments, and nursing care with patients that have GERD, C. pelvic inflammatory disorder, PUD, peptic ulcer disorder, peritonitis, and IBD. Okay, so you guys know this. This is the GI structure. Okay, basically it's all the way from the mouth to the anus. We're going to go into some specifics in terms of lower and upper esophagus, some of those airway issues and those kinds of things. But okay, so let's just basically do a review. Okay, what is the peritoneum? It's a lining, right? Pretty simple. It's almost covers all of the abdominal organs. Okay, and there's two layers. You have the parietal layer and the visceral layer. You don't need to know this A&P for the test. I'm just reviewing it because it correlates with some of the things that we have to talk about. Okay. Two sphincters of the esophagus. What are they? Upper and lower. Okay, and we're going to talk about those. Which cells secrete pepsinogen? Chief cells. And which ones secrete hydrochloric acid? Parietal. Okay. Why is the pH in the stomach acidic? Yeah, we want it to kill the bugs, right? We want it to be so acidic they can't live. And then the Valsalva maneuver, you guys know that, okay? Sit on the toilet, kind of press down, okay? What does that do to your blood pressure? Okay. Which diseases is this maneuver contraindicated? When would you not do the Valsalva maneuver? When would you not tell, when would you tell your patients to do it and not do it?
So not if you have ICP.
Okay. Portal hypertension, ICP.
Abdominal surgery.
Okay. See? Yeah, hypertension, hemorrhoids. Hemorrhoids is a big thing, okay? Yeah, you got it. Okay, functions of the liver, you guys know that. We talked about it yesterday. You know what the portal circulation system is and what it does. Okay, let's focus in on the geriatric considerations. And these are really, really specific. It's very important that you understand the differences. Primarily, in general, what happens as we age? Other than, the looks and all that sort of stuff. What happens to our bodies? Everything slows down. Every single thing slows down. So if you can imagine the changes that would happen while they're eating, those kinds of things. So let's just talk about some of the changes. Age-related changes in the esophagus. They could include what kind of, is your body processing food faster or slower? Slower. So you're gonna have delayed emptying, right? Okay. And that could result from what?
Smooth muscle weakness.
Yeah, smooth muscle weakness, okay? And you have reduced upper sphincter opening. And we're gonna talk about those specifics here in just a minute, okay? And then finally, you have an incompetent lower sphincter, okay? So you have one sphincter that's opening not the way that it should, and then you have another one that is so loose that it's letting food kind of do whatever it wants to do, okay? So, the liver decreases in size, but does it change in terms of its function? No. I mean, yesterday we talked about you could lose about 90% of your liver and it could regenerate. I don't know how that would work as we age, but we also know that if the liver is damaged enough, it won't regenerate, right? Okay. So basically, as we age, enzymes change, okay? They change in the liver, which decreases the liver's ability to metabolize what? Drugs. That is really, really important, because what are we doing as nurses? We're giving them drugs, right? I mean, I like to say medications because that sounds healthier, but we're giving them drugs, right? So Do they metabolize them as fast as we do? No. So what's gonna happen if you give an elderly patient some morphine and then they say their pain is still bad, so you give them some more morphine, and then 5 minutes later you give them more morphine because the order says that you can, what's gonna happen? Yeah, they're gonna be like comatose almost, right? You're gonna be like, oh my God, I gave them too much. They're almost going in respiratory distress, okay? Almost respiratory decline, almost that they're not breathing, okay? Also, what happens if you have someone that is, has some fat, you're obese? What about the drugs? What does that change to the metabolism of the drugs? Stores it, okay? Those medications get stored in that fat, okay? So if you have somebody that is geriatric and obese, okay, and let's just say they have sleep apnea, right? This is like the double whammy, okay? Well, triple whammy, actually. So, as I said, everything slows down. And I tell you what, it seems like every single time I'm with a geriatric patient, it's like they're burping or they're farting or they're doing something. I'm not being disrespectful, but truly that is part of the effects of aging, okay? Constipation is huge. Remember at the nursing home, how many of the residents that you took care of were on like 3 or 4 stool saws?
All
All of them, right? Okay. They also can have fecal incontinence or impaction. I was with, which student that I was with this past week in clinicals that they had a perforation in the intestines? Shannon, can you say what the details of that were?
Yeah, he had he got an ulcer so he had had knee surgery, was on pain medication, which caused an ulcer. Hold on, and
Sorry to call you out.
I know.
It's really interesting.
Oh no, it was, yeah, you're right, it was a bowel perforation, an ulcer caused a bowel perforation, and,
How did it work?
huh?
Why did it perforate?
Just because of the medication that he was on, so and the ulcer,
Huh?
yeah.
And he was constipated.
Oh, yeah, well, I'm trying to think, yes, you're right, yeah, he was constipated,
Okay.
and so probably.
Yeah,
trying to go.
they were suspecting that his intense constipation and the length of time that he had the constipation
Yeah,
really perpetuated that perforation.
yeah,
So can you imagine how impacted he must have been?
but it was only like a week,
Yeah,
like it was, yeah, it was
it's a
very
very short amount of time. So not only are things slowing down, all the vessels and everything are a lot more fragile and more delicate, so they're more apt to have things like that happen. Okay, so food intolerances, gas, we talked about that, loss of teeth, okay, taste and saliva equals weight loss, but in terms of what we're really concerned about, if we have a patient that is eating, right, what happens if they don't even recognize that the food's gone bad because it tastes bad, right? Their whole way of how things taste are quite different, okay? Make sure I'm hitting all my high points here. So, what is a rutitation? It's a fancy word for belching, right? Sometimes you're gonna hear that in the charts. I wanna make sure that I go over those last 3 words because you will see them in the charts, okay? Pyrosis, what's that? Heartburn. And then dysphagia, what's that? Difficulty swallowing. Sometimes they can even feel like they have almost like something stuck in their throat. Okay, kind of talked about this. These are some of the concerning physical assessment findings. By the way, that table is the old listing, so it's actually chapter 4310. So you might want to just change that in your notes if you're looking for that exact table, okay? The way that I like to think about it, and somebody had taught me this a long time ago, and I still have to write it down. So if you're having a hard time remembering some of the assessment abnormalities that happen with the geriatric population, you can think of it as 5 F's for distension. So flatus, fat, fetus, fluid, or feces. I always thought that was fun. And then, of course, you have multiple things that could cause any one of those issues other than the fetus, right? You're not gonna have a fetus with a geriatric patient. Oh, sure. So, flatus, fat, fetus, fluid, or feces. Like I said, sometimes it just kind of helps when you're thinking in your head about your abdominal assessments. Okay. So I keep talking about bleeding, gastric bleeding, because it's very, very common, believe it or not. If your patient is bleeding, what do you think you're feeling? If they have a GI bleed, okay, not only are they spitting up that blood, they're swallowing it, okay? Sometimes if your patient is saying, hey, my stomach really, really hurts, and they start to vomit, okay, you just start putting the pieces together. Obviously, if you see blood, you know something's going on, right? But it could be that they just had surgery in their mouth, okay? And maybe they've had a TNA, a tonsillectomy, and an adenoidectomy. So basically, the tonsils are removed and the adenoids are removed. So everything is kind of like back in there, but the surgeons have to use the mouth to get in, okay? So you're gonna have patients that could potentially be spitting up a little bit of blood, okay? Or you could have somebody that has truly a GI bleed, and the bleeding is coming out from the rectum as well as they're throwing it up as well, okay? So just be aware, kind of put the pieces together. Okay, so I point this out just because you could have acute or chronic bleeding, okay? Hopefully it's not chronic. Obviously, their hemoglobin and hematocrit are gonna be super low. If they have chronic bleeding, iron's gonna be an issue, all those kinds of things. Let's go over these terms. Hopefully you know them. If you don't, that's okay, because I got them right here. So what is melena? Black, tarry stool. Okay, that's obviously indicative of blood that's in the stool, okay? Hematochezia, that's a hard word to say.
Fresh blood in the stool.
Yeah, okay, because it's fresh blood in the stool because the blood is coming very, very close to the anus, okay? So you're kind of figuring out, okay, is it fresh blood or is it old blood, okay? How about rectoregia? What about that?
Just blood.
Just blood,
Yeah.
yeah, okay. And hematemesis, I think I'm saying that right?
Throwing up blood.
Okay, blood and vomit. Yeah,
So rectoregia would be blood without stool, is that what you're saying?
no. So it's blood that's so close to it's so close to the colon, it's gonna be, really red blood.
So then how does that differ from hematochezia?
That's a good question. So one is close, the hematochezia is next to the anus, and then, hang on, let me make sure I'm saying this right. It's hard to say these words. Since the anus is so close to the colon, that's why you have the hematochezia, and then fresh blood is usually caused by the lower GI. So, let's see, the rectoregia is any blood that passes through the anus, and the hematochezia is fresh blood that's come from the colon.
Some of the differentials we're seeing is rectoregia is just blood, like no stool.
Yes, yes, I probably should have said that. I'm struggling saying the words, that's my hard part. But the important thing is that you guys recognize those words because you will see them in the charts, okay? Okay, but please look them up. I probably said them all wrong, but it's important that you know them. Okay, let's talk about rebound tenderness. We talked about a couple of things that would indicate that, right? Do you remember some of the different signs from patho that tell you what you're gonna find in that right quadrant? Appendicitis, okay? Does the book mention McBurney's point? I couldn't find that in the book. Did they mention that at all? I didn't see it. So basically, McBurney's point is another thing that they use to assess appendicitis. So basically, it's rebound tenderness. Okay, it's about 2/3 from the midline of the umbilicus is the point in itself, and then you press on it, and pain. You feel pain when you release it. Okay, and that could be a sign of appendicitis. But obviously, that's not, you know, you're going to be doing diagnostics, but that is one thing that the doctors recognize. Okay. Okay. Nursing responsibilities. We briefly went over some of the diagnostic studies in the GI system. The important thing is that you recognize what kind of diagnostics doctors are going to be doing for what test. Okay, so let's talk about endoscopies and upper endoscopies. Okay, if you have a patient that is going to have either an upper endoscopy or lower endoscopy, what is the nurse's responsibility? You prep. You're prepping them, right? Are they going to be NPO? Yeah, they're going to be NPO status, right? Okay, so they're going to be doing a little bit of propofol. Who was in a GI lab over their clinicals this past week? Okay, did you see any endoscopies being done? Probably quite a few. So what, if you have a patient that has been sedated specifically for anything that is going through the mouth, are you going to offer them water right ahead? No, right? You're going to make sure they have their gag reflex back, okay? Because if you don't, they might aspirate, okay? So, in terms of common diagnostics, you could be doing endoscopies, you could be doing colonoscopies. Those are the biggies, okay?
What's the difference between the lower endoscopy and the colonoscopy?
What's the difference? Just where they go. So, the lower endoscopy, they basically go through, they go through the mouth. Anything endoscopy is through the mouth, and then a colonoscopy is through the rectum.
Even a lower endoscopy?
Yeah.
Can you show right there, it's still through the mouth?
Yeah, that's what at the GI lab, that's what they told me. So, even though the machine is going through there, yeah. That's what I was told. So, yeah.
It's gonna see everything.
Yes, they're checking different parts. This is your colonoscopy. Okay? Who's ever had a colonoscopy? Did you have it because the doctor said you need to have it because of family, or were there, if you don't mind me asking, were there issues with your?
Just age-related preventative.
Okay.
They moved the age earlier.
Yeah, so they moved it to 45, right? They moved the age to 45. So I want to show you guys something.
It was great. It's the best thing I've had in so
So anybody know, I know you guys know who this is. Yeah. Right? So he died at 42. Okay? He died at 42 of colon cancer. Okay? So I put that up there because a lot of students don't recognize how important it is if you have a family history, and I'm not sure that he had a family history of colon cancer, but it's happening to everyone in all different ages. The thing that they're looking for are polyps, okay? When you have a colonoscopy, they're looking for polyps. And the doctors have told me that typically what happens is that they go in and they remove all the polyps that they see, okay? Because the polyps can turn into cancer. Usually it takes about 10 years for those polyps to grow to a size that they become cancerous. So oftentimes they'll stop doing colonoscopies for someone that's in their late 80s, mid-80s. I think they cut it off at 80. But anyway, so as you can see, there's all different kinds of things that they can recognize in a colonoscopy. They usually just go to the cecum, by the way, which is this little part right here. As you can see, they go through the rectum here, and then they stop here, right at the cecum. They don't go to the small intestine because it's too tortuous. It has too many twists and turns. Okay, so let's talk about GERD. You guys need to know about GERD. Who has GERD, by the way? Anybody here? It's pretty prevalent,
Medicine for it.
right? So how do you feel when you are having some symptoms of GERD?
I've taken Prevacid for like 20 years, so I don't have symptoms anymore.
Okay,
Because my doctor told me that even though they're not totally sure about the long-term effects of those PPIs, it's better that your esophagus isn't eroding, because then you're at risk for Barrett's esophagus, which is like cell change, like metaplasia, which is precancerous. So
yes.
They just said, go ahead and take them. It's like the lesser of two evils, but I don't have any symptoms when I take that.
That's great. That's good. I knew they took, was it Zantac off the
Yeah,
market?
it's off the market.
Yeah, they took Zantac off the market because, apparently it caused cancer. But,
Cool.
yeah. Okay. So, let's talk about GERD, okay? It's a chronic condition. A lot of folks have it. Basically, you have that regurgitation of the acid going up into the esophagus from the stomach, and it causes mucosal damage, okay? It's not really a disease, just a chronic condition. The big thing that you recognize is that there's various causes, okay? So those, as we age, those sphincters that we talked about, elderly in particular, that sphincter becomes very, very lax, okay? So that can allow acid to come up and have that regurgitation. You can have decreased emptying, so your stomach is not emptying as fast as it should, so the acid can just go up there. And then the hiatal hernia, which is really what we're gonna focus on. That's one of the biggies. If you have a hiatal hernia, most likely you can have GERD. So what are the risk factors for GERD? Diet?
The eating right before bed and then like going down.
Yeah, well, that gives you the symptoms of GERD. Yeah. So, diet, which would be obesity, right? You have somebody that's very, very large, okay? You have all that pressure building up from the stomach, okay? And especially they have that delayed emptying, so that could press up in there, and then you can have some of that acid regurgitation. Smoking is huge, okay? Pregnancy, okay? Nothing you can do about that. A lot of pregnant women have GERD. What's that?
No, please share.
I mean, you just said there was nothing you could do about pregnancy.
Right.
It's Colorado after all.
I was gonna say, you could take medicines while you're pregnant for GERD, but they suggest that you don't. But no, once you're pregnant, you're pregnant. Okay, alcohol is a biggie, okay? And obviously having a hiatal hernia, okay, we talked about that. Okay, so this just explains how that sphincter, basically isn't working properly, okay? So that's what that incompetent is. Okay, so hiatal hernia basically is kind of like a portion of the stomach, kind of protrudes up into the esophagus, okay? And that's how they're getting all that extra kind of acid, okay? The neat thing about it is you can take medicines, which we'll talk about here in just a second, but you can also have a procedure called a Nissen, they call it a Nissen fundoplication. Basically, it's this little part right here. They take a portion of the stomach and they wrap it around, so it kind of makes that a little bit, so it's not so open, okay? And that's an outpatient procedure as well. Okay, I like this picture because everything in this picture is wrong, at least for health-wise. Okay, so these are the things that you're gonna be teaching your patients about if they have a hiatal hernia, okay? The thing is, you're trying to reduce pressure, okay, intra-abdominal pressure. So if you have super, super, super tight pants, okay, that is going to increase your pressure. Tight panties, they tell you not to wear those either. You're better off not wearing any. Constricting clothes, okay, so basically anything that is constricting, okay, you're gonna avoid heavy lifting and straining, okay? And we already talked about some of the risk factors, okay, stop smoking, alcohol, obesity, you're gonna lose some weight. And one of the things that, Carson had said about positioning, or was it Isaac that you just said about, after you eat?
Oh, like eating, saying, sitting up.
Yeah, so after you eat, you wanna sit up, and we'll talk, I think they say about 2 hours. And those shoes, ouch, right? Okay, that's all that is for looking. Okay. So if you have a patient that comes in and says they have a heartburn, they feel like they have this tightness in their chest, immediately what are you thinking? Right, you're thinking heart attack, okay? But is that your call to make, that you're like, no, they just have some acid reflux? No, you gotta do a full workup on them, okay? You're gonna do every test known to mankind to make sure that they're not having a heart attack, okay? But just so you know, that heartburn, fibrosis, mimics how they feel with having a heart attack, okay? Also indigestion, okay? I'm sure that Jameson had gone over with you some of the things that, some of the symptoms that can be very benign when these females are having a heart attack. So just so you know. Anyway, so clinical manifestations of GERD, we have heartburn, indigestion, excessive, what am I thinking, saliva, regurgitation, okay? Respiratory symptoms, that's really, really important. So let's talk about the respiratory symptoms. What do you think you might have? Cough?
Wheezing.
What's that?
Wheezing.
Wheezing. Wheezing is huge. What else?
Is hoarse voice part of that?
What's that?
The hoarse voice?
Yeah, a hoarse voice, definitely. And just kind of like difficulty breathing, okay? Just general. Really, the stomach acid can cause severe inflammation, okay? So that makes it really, really hard to breathe. We briefly talked about that, okay? Positioning, specifically, they say that they do not want you to be supine for 2 to 3 hours after your meal. So you're sitting up in a chair, okay? You're sitting up somewhere. You're just not lying down. Some of the foods specifically to avoid with GERD, you want to avoid coffee, chocolate, fatty foods, basically all the really yummy stuff. And then post-operatively, if they have a surgery, they're going to feel kind of bloated. They're not going to feel like themselves, okay? Sometimes the abdomen can be pretty distended. And then if they have that surgery, they can pretty much eat as usual, but their stomach's going to be a little tiny smaller than what it was because obviously they wrapped it around the esophagus. So, but it kind of returns eventually. Okay, so treatment for GERD. There's a whole bunch of things out there, okay? We're going to focus on the proton pump inhibitors and the H2 receptor blockers because those are the ones that work the best, okay? As we said, the Zantac was taken off the market, so we're not going to focus on that one. The proton pump inhibitors, the best way to remember it is that they end in zol, okay? Like omeprazole, that's one you're going to see a lot, okay? Who knows what some of the complications are of some of these drugs? Kind of general, kind of benign. You can never go wrong with GI upset, right? The question asked you about that? Okay. Constipation, dizziness, stomach pain, those kinds of things. Okay. One thing that's important to recognize, and I tend to forget this myself, is that these drugs can cause hypocalcemia, okay? So it reduces your body's ability to absorb calcium, okay? So if you have a geriatric patient that has been taking these medications for, say, 20 years, what are you going to be worried about? What's that? Yeah, osteoporosis, any sort of You know, anything that is going to be affecting calcium is going to be affecting their bones, right? Okay, so their bones are going to be less, they're not gonna be as strong as they once were. Not only that, they're older, so that's just part of the equation. But just something for y'all to think about.
Because it's stopping parietal cells, is this the one where you can get anemia?
You know, I don't remember why. I don't remember the patho behind it.
These parietal cells, right? Parietal cells, your intrinsic factor, which is.
You're going way down a rabbit hole.
Yeah.
Way down a rabbit hole. Just focus on the fact that they reduce calcium. That's all you need to know right now. Okay. Okay. So Nora briefly mentioned this, okay, complications of GERD, okay? She particularly takes some medication because she doesn't want to have this sort of complication with the esophagus, this chronic erosion, okay? It does eventually, if it's continuous, can cause Barrett's esophagus, okay? And you can see up on how it's eroding now, okay? Not only when you have GERD, you can have stenosis of the esophagus, so a narrowing, just from that constant inflammation. Dental erosion, obviously it's hurting your teeth, you're not sleeping well, and most of all, if that hiatal hernia ruptures, you can have hemorrhage. Peptic ulcer disease. Okay, do you guys remember this question from the beginning? What causes it? There's two things that cause it. Biggies. NSAIDs and H. pylori, okay? That's what you need to know. And obviously, you're going to be using NSAIDs because of a certain lifestyle that you're having, okay? You may be having this continual GERD and you're not feeling well, those kinds of things.
Hey, Robin,
Yeah,
what's ASA?
aspirin.
Okay.
Okay, so H. pylori, right? It's the most common cause of peptic ulcer disease. 2/3 of the world is affected, okay? It can survive a really long time, okay? Basically what it does is it alters the cells, okay? Causes tissue damage, okay? Get some nasty ulcers, but not everybody has them. What would you think if somebody has peptic ulcer disease? What are the biggies in terms of complications? We've talked about this. Bleeding, right? Bleeding, okay? Hemorrhage is the most common complication of peptic ulcer disease. Okay? Peptic ulcers may lead to bleeding or perforation, and obviously that's an emergency situation. If you have a perforation, that could be even worse, right? Because it's kind of a slow bleed. And it's really the most lethal of the complications. And the worst thing about it is that you can have the spillage go right to the peritoneal cavity. Right? And if you have an obstruction, you know what that means. Basically, everything's just backing up. Okay? These are your studies that I want you to focus in on. Okay? Your EGDs, that's the endoscopy. Okay? I had a lot of patients ask me if, once they have an endoscopy, if the doctors could see if they had H. pylori, and the answer is no. They still have to take biopsy and then send it to the lab. And as you can see, they're going right through the mouth. Okay. Okay. So the drugs that are responsible for this, what are they going to be helping with, right? Okay. If you have this peptic ulcer disease, you have a lot of inflammation, things have a lot of acid, okay? Lifestyle modifications are going to be huge with this, okay? They're going to be avoiding all kinds of foods that cause distress, basically. Acidic foods, we want to avoid cigarettes, avoid smoking, reduce or even eliminate alcohol use. And a lot of patients, what they'll do is they'll try all these over-the-counter medications in combination with NSAIDs, and that really makes a mess. So the best thing that you can do is tell your patients that they have to have antibiotics and the PPIs, okay? They just can't keep taking Prilosec or Prevacid and hoping that things are gonna go well, because it's an infection. Does everybody understand that this infection causes septic ulcer disease? Okay. So upper GI bleeds, we're gonna take a break here in just a hot second here. Mallory Wise, okay, it's kind of an unusual thing that happens. Anybody know what that is? It's basically a tear when they cough. Okay, they cough so hard that they have a tear in that region. Could be in the esophagus, usually it's in the esophagus, okay? And these are some varices that you could get. I don't want you to focus in on that. Let's take a break, okay?